From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA Clinical Reviews podcast. I'm Dr. Kirsten Bibbins-Domingo, and I'm the editor-in-chief of JAMA and the JAMA Network. I'm joined today by Dr. John Ruiz, professor of clinical psychology in the Department of Psychology at the University of Arizona. Dr. Ruiz is also Associate Director of Equity, Diversity, Inclusivity, and Accessibility at the University of Arizona Cancer Center. Dr. Ruiz is a member of the U.S. Preventive Services Task Force, and he's joining us for a discussion today about the new Task Force recommendation statement on interventions to address high body mass index in children and adolescents. JAMA has published this recommendation statement and the evidence report on which the recommendation is based. Dr. Ruiz, thank you for joining me here today.
Thank you so much for having me today. It's certainly a pleasure to have this opportunity to talk about our nation's health, in particular our children and teens who we care deeply about.
Yes, and we know that obesity in childhood and adolescence is a big problem. So why don't you start with the high-level summary of what the task force is recommending?
Well, as we know, nearly 1 in 5 children and adolescents living in the United States have a body mass index, or a BMI, the standard measure for what is often referred to as being obese. 1 in 5 children has a high BMI. The task force understands the health implications of that, both mental and physical, and looked at the evidence regarding the degree to which that can be controlled and balanced. The task force reviewed the evidence, looking at both the balance of benefits and harms of interventions to promote a healthy weight, and found that intensive behavioral interventions of 26 hours or more with a health professional in a given year were moderately effective to achieve a healthy weight and improve overall quality of life.
Great. That sounds really important. The task force has found that there is evidence for interventions to address this important issue of obesity in childhood and adolescence. Give me a little bit more of a sense of what these interventions are like. You've talked about the duration, but what is exactly involved in these interventions?
So these are intensive behavioral interventions, as noted, 26 hours or more with a health professional a year. These are multi-component interventions, including supervised physical activity, education around a healthy diet, and importantly, working to find strategies to implement behavior change. We've all tried to change behaviors, typically on New Year's, and had varying degrees of success. Understanding how to do that is an important component to achieving not only an immediate change in behavior, but one that is long-lasting that will have health implications. The task force also found that there was a dose-response relationship where the more intervention done, the better the outcomes. And very importantly, those interventions that involved parents or family achieved better outcomes as well.
So does more mean longer duration? Does it mean more components? Does it mean more regular points of contact? How do I think about more?
More is broadly defined as longer engaged. So here we looked at 26 or more hours of intervention. So I would really think about this as the amount of exercising, dieting, strategizing that the person does. Of course, there is a dose response where longer sessions are going to have more immediate kinds of impact. But what we're really talking about is a behavior change, one that is adapted and adopted for a long period of time. We have to think about the new behavior. We have to strategize about it. But after a while, it may become habit. And once it becomes habit and integrated into a person's life, it's much more likely to have intended effects. In this case, we found that those interventions that are 26 or more hours a year had the better effects.
So who is delivering these interventions, and are they available in most primary care settings?
It's a really important question, implementation. In most cases, we would hope that there are one-stop shops, an opportunity where a referral can be made in the primary care setting to a place where there is these multi-component efforts going on. But of course, that's not going to be for every family, every case, every context or location. People's lives really vary. As long as they're getting aspects of this multi-component intervention, some physical activity, help around diet, help around strategizing for 26 or more supervised hours a year, then we start to see the benefits of this intervention begin to take hold.
It's really excellent to understand that there is evidence for these types of interventions and that this sounds like it will likely be referrals from primary care to hopefully places where these can be delivered together. But there are other types of strategies and approaches to obesity in childhood and adolescence, and we know about many of the newer medications that have been approved, and those approvals have been for childhood and adolescence as well. Did the task force look at the evidence for the medications to treat obesity?
The task force did look at the evidence regarding medications, but at this time found that there was insufficient evidence with which to make a concluding statement about them.
Where is the gap in the evidence, given that these have been studied? We certainly know they're part of the medical and the lay press. Where is the gap in evidence from the task force perspective about routinely recommending these?
I appreciate that you mentioned that we see these in the lay press, and we certainly do. It's something that is common discussions around the kitchen table these days in many households, the effectiveness of these medications and their potential. But I would frame it much more as potential at this point. The evidence base regarding those long-term harms and benefits have really not been well documented at this time. Certainly, we need more evidence to know that whatever changes take place, whether those are sustained, whether they have health implications, and whether those health implications are good health implications, in other words, beyond simply just weight management, but also that they're avoiding harms that may come with the side effects of many medications. At this point in time, there simply is a gap in that knowledge base, and we're hoping that over time from this recommendation that those begin to get addressed and that we can have better evidence with which to make a determination in the future.
So these medications have been shown to reduce weight, at least for studies that were over shorter periods of time. Is the gap then that we don't know the longer-term effects, both benefits and harms, which might be particularly important for children? Is that the main gap?
It is part of the main gap. Certainly, we want to have an evidence base that reflects the population broadly in its diversity. We also want to know whether those short-term effects are sustained over time. And importantly, we do want to know those health consequences. Many things might look promising at one point, only to find that later on, they don't necessarily have the intended effects that we had hoped that they would. At this point in time, the evidence just simply is not sufficient with which to make a determination.
So 1 in 5 children, 20%, that's very important and large proportion of the children and adolescents. But we also know that there are gaps that some children and adolescents might be more likely to both suffer the consequences of obesity, and we might have to pay particular attention to making sure that these types of interventions reach those. How does the task force think about the epidemiology here?
That's a really important point. We certainly know that the burden of obesity is not equally distributed in our populations. There are certainly some groups, Black, Hispanic, and Latino, American Indian, and other populations who are overrepresented and disproportionately burdened by obesity. When the task force thinks about its recommendations, it wants to, one, make sure that the literature it's reviewing reflects those populations, and two, that its recommendations are broadly available. Implementation through primary care is a good start to an equity approach to addressing this issue for all of the nation's children and adolescents.
So I think that's such an important point to make, because the children that might be most likely to be affected, the task force has made clear that making a strong statement about what works will hopefully improve the accessibility and awareness of getting these interventions. But even for the non-pharmacological interventions where there is this strong evidence for this B recommendation, is the task force concerned about accessibility of these to the many different populations that might have less access?
Certainly, accessibility is a major barrier to health equity broadly in the United States, not just for children and adolescents, but for all people in the United States. When we talk about this being a multi-component intervention, the prescription is not for specific types of services, but rather broad categories of service: physical activity, education around diet, support to learn strategies to implement. And those can be gathered and accessed through a variety of ways, depending on where the person is and what their particular context is. Many families have very different life circumstances that challenge them in a variety of ways and lead to very different access. By having these be broad categories that need to be addressed, it provides some flexibility to hopefully allow those different life circumstances to still have access to the broad knowledge evidence based around this care approach.
We talked a little bit about the gaps in evidence for the pharmacological interventions. Are there other types of gaps in the evidence base that the task force would like to see more research in?
The task force would certainly like to see longer-term outcomes for all of these interventions. We know that these approaches have success in the short term and that the balance of harms and benefits certainly leans towards benefits as expressed by the B grade. What we know less about are the long-term health implications. What happens to kids who manage their weight effectively or ineffectively 10, 20 years down the line? Is that a precursor to many of the adult conditions that we see later? Having that evidence would allow us to more concretely say that there is not only a short-term benefit during adolescence and early adulthood, but in the later years where we also see many chronic health issues arise from issues such as obesity.
What should clinicians know? What should patients and families know about what interventions work for addressing high body mass index in children and adolescents?
Well, certainly we know that obesity is a common experience in our populations, from teens and children to adulthood. We all tend to face this issue at some point. It's important that people know that a healthy weight can be achieved. Task Force in this case reviewed the evidence regarding interventions and found that intensive behavioral interventions, multi-components involving physical activity, healthy diet, strategies around implementation of 26 hours or more in a given year with a health professional could be helpful in achieving those outcomes with a moderate degree of certainty. It's important to also note, and perhaps we underemphasize this a little bit, but it certainly is a part of our everyday experience, that effective weight management and these kind of interventions also promote a healthy quality of life. And having that healthy quality of life, being able to look forward to one's day, is an incredibly important part of our existence in the moment and in the long term.
Wonderful, wonderful. Thank you so much. I've been speaking today with Dr. John Ruiz, a psychologist and a member of the U.S. Preventive Services Task Force. We've been speaking about the new task force recommendation on interventions for high body mass index in children and adolescents. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.